All right, 5, 4, 3, 2, 1.
Hey, good morning, everybody. It's Dr. Jay Harness, welcoming you to another live Google Hangout here at Breast Cancer Answers. And we are having a really wonderful hangout today. We have two very special guests with us, and I'm going to introduce them here in just a minute. And what we're going to be focusing on today, and once again later in the month, we're going to be focusing on male breast cancer. Now, when we think about the world of breast cancer, of course, we think about women. 99% of breast cancer does involve women, and among men, breast cancer makes up actually less than 1% of breast cancer, or excuse me, of all cancer diagnoses in men. And it's one of those things about a diagnosis never thought of as a diagnosis never made, and we're going to be emphasizing this morning the examination of the male breast by ourselves as men, and we're going to be emphasizing other aspects of what this month, April, is Breast Cancer Awareness Month for men. Let me start off by first introducing Brett Miller. Brett, welcome, and tell us a little bit about your association, and you're a male breast cancer survivor, and later on you're going to be showing us how to do the breast self-examination. Brett, welcome, and tell us some more about yourself and about your organization.
Good morning. Thank you for having me. Yeah, I started a foundation. We call it the Brett Miller 1T Foundation, and our goal is just to spread the awareness about male breast cancer, letting people and letting other men know that it's possible. Because I've meet men every day, and sometimes I'm wearing my shirt, you know, the one I've got on right now, and it catches their eye.
Whoa, wait a minute, Brett. Stand back up there. So give us a chance to read it.
Sorry.
Don't move around too much. So what does it say, guys? And
it says, "Guys, don't be afraid to touch yourself." And on the back, it says, "Men does not escape breast cancer." And it's just our way of trying to get everybody's attention to let them know that men, you can too get breast cancer. Just recently, we started a male breast cancer coalition. We've teamed up with several other breast cancer foundations in the U.S., and we're just trying to spread the word nationally to men, and that just to get the extra, the extra help that we need for people that are up in New York and D.C. and everything. Where that's where some of our major input's going to be, to get the help from them. And yeah, I've been on the Katie Couric show. Just recently was out for the doctor's show that'll air soon. They did a little piece on the male breast cancer. We're just trying to build the awareness to men, to build it as much as how women's breast cancer is right now.
Now, Brett, having done those kinds of national shows that you've done, and I just think that's absolutely fantastic. Clearly, people will ask you, well, gosh, Brett, what are the statistics about male breast cancer? As a male breast cancer survivor yourself, you probably have those at your fingertips. So why don't you share with our audience what you typically tell people about the incidence of male breast cancer, and then we'll get into your story a little more later on.
Great. As you said earlier, it is only 1% of all breast cancer cases are males.
All cancer cases are
all
male.
Cancer. Okay. And it's this, some of the stats say that it's most commonly there's a lump directly below the nipple. Which is what my case was, but I had the lump for 7 years. And the average age is between 60 and 65. And I was 24 when I was actually diagnosed. I found it when I was 17, though.
Right. Now, and actually, it's actually, when we talk about this 1% number, it's actually for both. It's actually for all breast cancer cases reported nationally here in the United States. About 1% are in men, so you're correct in what you said. And then if you look at all cancers among men, it's actually slightly under 1% of all cancers among men actually end up being breast cancer. Brett, do you have any actual hard numbers for us? I mean, do you have any clue how many thousand men we're talking about in the United States with the disease?
It's right around 2,400 that get diagnosed a year. That's the American Cancer Society's statistics. And of those 2,400, like 400 to 500 will die from it, which raises that percentage above, well above like 20%. And that's where we think that's too high. And we've been told by others that it is only 1%. It is not that large of a population, that it doesn't need that much awareness. I see differently. I'm a breast cancer survivor.
Yep.
I want to change it. I want to make other people realize that it's possible.
All right, perfect. Well, that's a perfect segue to our other guest, Kathy Freelander Cole, who's a nurse practitioner at Los Robles Hospital here in Southern California. Kathy is a dear friend of Breast Cancer Answers, and Kathy, you and I were just together a few weeks ago at the National Consortium of Breast Centers National Meeting in Las Vegas. So two things, Kathy. A, tell our audience about the National Consortium of Breast Centers, and then also, Kathy, help us frame the issue of the incidence of male breast cancer in the big picture of all breast cancer. But welcome, Kathy, and it's all yours.
Well, thanks, Jay. Good morning. And Brett, it's a pleasure to work with you too. Greetings from Southern California, where it's over 90 degrees today, and it's only April. Like Jay said, I'm a member of the National Consortium of Breast Centers, been involved with them for almost 20 years. We're entering into our 25th annual year in 2015. This is a wonderful organization that brings together nationally recognized comprehensive breast centers across the country, and we even have an international global perspective now for breast centers around the world, and we look at best practices and share ideas, break out into sessions on everything from how to run a breast center to the latest technologies and diagnostic treatments. So it's an honor to be a part of that, and I'm on the Planning Commission this year, so we'll be looking at great new things to present next year.
You know, at the times that you and I have been at the meetings, and here's a little trivia for you, Kathy. The actual second meeting of the National Consortium of Breast Centers was held in Ann Arbor, Michigan, I think around 1988, on the back end of a wonderful meeting we held there about multidisciplinary collaborative breast cancer care. And so to see you and the others who have been involved through all these years, fast forward now, as you said, just about 25 years later or so, it's really a treat.
It really is, and we're growing.
But when I think about our wonderful national meeting that we were just at, I don't think we talk about male breast cancer, do we?
No, we don't. And what's really important, I think, is I chair the CBE committee, which is a pre-conference course on developing skills for detection of breast cancer. And I made it my business this year to talk about men because I think it's overlooked, it's underdiagnosed, and I think clinicians have to have an awareness when a patient presents to be able to say, yes, this is a possibility. I think I can't overlook working this up.
Yeah, and then there's sort of what I want to call right now the embarrassment issue, because in my practice, which is full-time breast disease, I see men with gynecomastia. And for our audience, that big fancy word gynecomastia means enlargement of the male breast. And certainly probably close to, again, 99 times out of 100, that's not breast cancer.
Right.
But Kathy, I go ahead and order mammograms because we want to make sure with the enlargement of the male breast that it's not, in fact, a breast cancer. And so what we do at our center is we have a little separate area for waiting for men who come in. This probably happens a couple times a month to get their mammograms done. How should that work as far as the national consortium goes? What should we be telling breast centers?
I think it's just as you said, Jay. I think we have to raise the awareness, and if a male patient comes with some sort of breast complaint, I think we just have to keep it in our critical thinking, in our differential diagnosis. I think we just don't automatically rule that out. There's lots of reasons why there's gynecomastia or nipple discharge, and you have to really do a thorough history. But I think you're quite right. I think we just cannot ignore the fact that until proven otherwise, especially in the older population, we do have to make sure that we're not overlooking a malignancy.
Yep, absolutely. Now, you said something that's really key that I want to get back to Brett about, and that is history, family history. And actually, men can be BRCA gene carriers. Men who develop breast cancer should be tested for BRCA1 and 2. So, Brett, let's jump back to you. Tell us your story. I think I've heard it before, but our audience today would like to hear it. In other words, you had this lump for 7 years that everyone thought, oh, you're so young, this is nothing. So tell us what actually led to your workup and how the workup worked for you.
Well, yeah, I had the lump for 7 years. When I found it when I was 17, I had been to the doctors, and there was a physical night at my high school for upcoming fall sports for football, and I mentioned it then. And the two doctors that I had gone through at the time, they had both said that it was a calcium buildup. It was going through puberty. It'll dissipate and go away. Fast forward 7 years later, still never went away. I got health insurance for my job, and I went to I just wanted to go get a routine physical because it had been so long. And I went out there, met with my doctor. He tested me on everything, and everything came out great. And he asked if I had anything for him. Told him about the lump. He sent me to go get an ultrasound. And so I had to go to the women's clinic to get the ultrasound.
All right.
And so there's an awkward situation right there, and an embarrassing one at the time. And while I was in there, the doctor that's on call comes in and says that I need to do a mammogram. So we did the mammogram, met with the surgeon, and he looked at all the scans, and he looked at it and just thought it was nothing. But for the period of time that I had it, he would rather just take it out just to get rid of it. So they took the lump out, and then the next day I get the call from the surgeon saying that it's breast cancer.
All right, now let me jump in because there's several really, really important things that you brought up here, Brent, that are, again, more common. So you were how old again? You were 17 when this was going on?
17 when I first found the lump, and 24
Okay.
when I was actually diagnosed.
Okay, good. So let me just jump in on the fact when you were 17. I do see 17-year-old men as a breast clinician with enlargement of a breast, and there are things that are hormonally imbalanced, and generally that should all disappear within a year or two. So the big thing is reassuring the patient. I think doing the ultrasound like you had done was really important as well. Now, let me put out there that among that age group, 17, 18, early 20s, another cause of male breast enlargement is actually the use of marijuana. Marijuana can suppress testosterone. Men need to know that we have both hormones circulating within us. We have both testosterone and estrogen. And so when you suppress the testosterone by the use of marijuana, the estrogen level goes up, voila, you have an enlargement of the male breast. Your story, thank goodness you were worked up the way you were, Brett, but your story has some usual factors to it, but it also has unusual factors to it. So what happened? So he did an excisional biopsy that made the diagnosis. What was your next treatment, Brett?
Following that was a mastectomy, where they removed the nipple and they did a 1-inch margin around the nipple to get the clear margins, and they did the sentinel node biopsy and stuff, and they tested and it didn't spread anywhere, so I was essentially all clear.
Yeah, and what's interesting about your history with that long, long period of time the 7-year lead time, that says a lot about the biology of your cancer. And the good news here is your sentinel nodes were negative, and this is a low biology. Thank goodness for you. Now, we also have some pictures of you at Breast Cancer Answers, because you've gone on and done something pretty neat, and maybe you'd want to show our audience now. If I remember correctly, you've got quite a tattoo over that side, right?
Yep.
There you go. All right.
It says live, fight, and survive. I've got the pink in the front and the blue behind, because every time you think of breast cancer, you still think of women, but men can get it too. And also with the men, when the women get it, the men are your support system. And then I've got the dates of 4/28 and 9/21 of 2010. That's my diagnosis date, and then my last date of chemo.
Oh, good for you. Good for you. All right, so we're going to get into the treatment here in just 1 second. But Brett, let me ask you this. I'm assuming, therefore, you were gene tested. Is that correct?
Yes, I was tested for BRCA1 and 2, and they were negative. I do not have the gene. There is, from what we could lay out in a family history, there is no direct line of breast cancer. There's plenty of breast cancer on my mom's side with cousins, but still no direct line.
Okay, very good. So I just want to remind our audience that BRCA1 and BRCA2 are the two genes we know about today. As we unravel the molecular mystery of breast cancer over this next 5, 10, 15 years, Brett, I'm convinced we're going to find, even with that family history, even though it's distant in there likely is some sort of gene abnormality that got passed along. Frankly, we just don't know about today. Now, you also then mentioned that you had chemotherapy. Tell us a little bit more about that, and what kind of chemotherapy did you get?
Yeah, well, my oncologist, you know, the surgeon said that everything was cleared, and then I still had to meet with the oncologist to figure out, you know, my course of treatment following if I needed radiation or chemo. My oncologist sent the tumor out to Oncotype DX, and that test was what gave my oncologist the better plan of attack of treatment, and it gave me a better idea of actually doing chemotherapy, because I was, you know, once they told me I was all clear, they're like, you know, you really don't need to do anything else. You're good. But the Oncotype DX test said I had a 22% chance of cancer coming back over a 10-year period.
All right. So time out again. Just for a matter of full disclosure, Genomic Health, who performs the Oncotype DX test, is a major supporter of Breast Cancer Answers. And, Brett, when we had an opportunity last year to interview you here at Breast Cancer Answers, I did ask the folks at Genomic Health, gosh, have you been doing the Oncotype DX on men? And the answer is yes. And so you got a higher recurrence score, and your medical oncologist did exactly the right thing. Mm-hmm. Now, let's explain to our audience, and I think this is really fundamentally important. A lot of people think, oh, gosh, just let's do big surgery, and I'm going to be fine. And I want to remind our audience that with invasive breast cancers, and Brett, that's what you had, an invasive breast cancer, you shed off cancer cells that circulate and go elsewhere in the body. So we've known for 30 years that you need to treat the whole body. And so there are two elements of treatment of the whole body. One is chemotherapy. And in your case, Brett, the Oncotype DX came back with a high enough recurrence score. That was the correct thing to do. And the other thing that we do then to treat the whole body in the estrogen receptor positive cancers is to use an anti-hormone pill such as tamoxifen. So, Brett, are you also on tamoxifen as well?
I was on tamoxifen for about 2 months, and family, mom, they all said it changed me. They said I was more, angry or temperamental or anything. So they took me off for about a month, and now I'm on anastrozole.
Okay, anastrozole probably.
Yes.
It's an aromatase inhibitor. And are you tolerating that okay?
Yeah, I've been on it for almost 2 years now.
Good for you. So again, let me just summarize. This is just fascinating. People need to understand that, in fact, the treatment of male breast cancer is the same as it is for women. And there are two aspects of that: local regional control, and Brett, in your case, and all men, we're not doing breast conservation. There's just not enough tissue to be able to do that. So you have a mastectomy. You had the sentinel node biopsy done, and you were node negative, which is great.
Mm-hmm.
And you got chemotherapy appropriately, and now you're on an aromatase inhibitor as an anti-hormone treatment, so you're being treated identically. Kathy, why don't you jump in and give us your thoughts about the treatment and particularly the diagnosis and treatment of male breast cancer?
Well, as you said, and Brett is a model for this, it's almost an identical treatment. We still stage just like we do for women, so it's about tumor size, it's about lymph node involvement or any distant disease. And surgery is the most common way to initially treat this, generally followed by chemotherapy and radiation. I think Brett, because he had an infiltrating, and it's mostly in men, a ductal carcinoma, I think he was appropriately treated, and probably his aromatase inhibitor, he'll stay on that pill for a number of years. Probably we have data to support beyond 5 years, as long as he's tolerating it well, and to continue good surveillance and to continue to see his physicians at regular intervals as any other breast cancer patient would.
Yep. And Kathy, also, let's comment about the diagnostic workup. It sounds to me like the only thing that I might have a little variance with his diagnostic workup is they did start off with an ultrasound, which I think was quite appropriate. They then went to the mammogram, which I think is appropriate. Frankly, at our center, and probably with yours and through the National Consortium of Breast Centers, probably the next thing would be actually a core needle biopsy.
Exactly, and that's the part I was thinking. Why go to excisional biopsy if you're trying to make the diagnosis? Just get some tissue and then set out the plan. I think that's the only variance I was thinking of when Brett was telling his story. In the end, it was all done correctly.
Yeah, no, you've had, and so Brett, you've had a multidisciplinary team there in Kansas. Where have you been treated?
At St. Joseph Medical Center was where I had all the surgeries, and then my the chemotherapy and meeting with my oncologist. He's out of KU Cancer Centers.
And
the South Page.
What city are we talking about here?
This is all located in Kansas City, Missouri. Kansas City, Kansas, Kansas City, Missouri. It's divided by a line down the road, the middle of the road.
Very good. Well, why don't we segue now into the male breast self-examination? I know we don't have a table for you to lie down on, which is what we generally recommend. And Kathy Freelander Cole is actually, when did we do that, Kathy? About a year and a half or two ago, I think you did the demonstration for us for breast self-examination for women. But Brett, why don't you at least stand up and give us what you're teaching other men about how to do the breast self-exam, and then I'll have Kathy chime in on how it's the same or different than women, okay?
Okay.
Yeah. I'll have to remove the headphones for this one, just so.
No problem. No problem.
Can you hear me?
Yes.
Yes.
I can't hear anybody.
It's okay. Go
there
ahead.
We go. There we go. All right. Well, should I take a shirt off?
Sure.
All right. So, Kathy, you want to chime in? You want to walk?
Yeah, I'll walk you through it if you don't mind. First thing you want to do is what Brett's doing now. You'll do that in front of a mirror, and you're really just going to take a look at the entire torso. Brett's turning from side to side because you want to see, do you see any dimpling, skin changes, other unusual skin manifestations? Is the nipple
Kathy,
being pulled in?
Hold on 1 second. Unfortunately, I think the camera is on you because you're talking. So let's do it this way. You describe what the step is, and then Brett, if you can hear me, go ahead and verbally say what you're doing so the camera will come on you.
Okay.
We won't show it to anybody, okay?
Dr. Harness, the camera is locked on Brett right now.
Okay, very good. So my director Marcus is. We've got the camera locked on you. So Kathy, you go ahead and describe it, and we're all set. Marcus chimed in. We're good to go here. So Kathy, keep describing. Okay.
Okay, so here we go. So we're looking at Brett, and we're looking at his entire torso. He's going to turn from side to side while he's looking in the mirror. And again, he's looking for skin changes or nipple changes, anything that looks unusual or change from what he's known in the past. That's good, Brett. Next, we're going to have Brett raise his arms up over his head. Again, this is another way of identifying anything that's changed. You have a better understanding of the anatomy, anything that moves along the chest wall. So again, turning side to side, you don't want to miss anything on the most lateral parts or the side parts of his torso. Brett, if you'd move your arms down now and put them at your waist and push in. Now, this kind of position, we teach everyone, regardless of gender, and when you're pushing in, you're flexing the pectoralis muscle, the chest muscle underneath, and you're really looking again to see what can be an underlying factor that maybe is pushed forward in this maneuver. Okay, Brett, that's good. And then you want to lean forward. This doesn't make as much sense in a man as it does in a woman, but you want to see if any change in position of the torso is going to project anything that's underneath the skin. And that's what we call the visual inspection. And just fundamentally, you need to know that most people focus on what is the area of the breast in a man or a woman. But what we're going to describe is a much larger perimeter, and we can't ignore anything within this perimeter, which most people think is quite smaller.
Mm-hmm.
Now, I guess we're not going to be doing lying down, so what we're going to do, Brett, you want to be able to check the lymph nodes too. You know, Jay can attest to this, but there are many times that maybe you don't feel something in the breast, but you might feel something under the arm, which is an enlarged lymph node. And then you're trying to discover secondarily, why is that lymph node enlarged? So we do want, Brett, if you take your opposite hand and you want to go into the armpit area, and you want to be able to go a little higher up, and you want to be able to feel underneath the armpit for anything that feels enlarged. Lymph nodes are generally like small little lima beans. You probably shouldn't even feel them. But if something is projected there, that's kind of a warning sign that something's going on. And you do want to be careful. Brett's using the 3 middle parts of his fingers. He's pressing down. These pads of the fingers are the most sensitive. People read Braille with this, so the detection using these fingers is quite important because you'll have a sensitivity greater than any other part of the hand, and you don't want to use fingertips because obviously that's not going to be comfortable. You'd repeat that on the other side. Okay, now we're going to have to envision lying down because we like to do this in 2 positions, but Brett, if you start in the armpit area, we call this the seam of a blouse, and I'm not too familiar with men's fashion. I don't know if you have seams along the lateral part, but you're going to want to start with the 3 middle parts of your fingers in the armpit region and slowly come down in a light, medium, and deep pressure. It's almost like a corkscrew because you want to be able to identify any kind of abnormality, an enlargement, a lump, that you might feel under any of these 3 fingertips. And you go down in a straight line in a light, medium, and deep way until you would get probably to the bottom of the breast tissue itself, where, now Brett, you're kind of off track here. You want to stay in a straight line, and this is the hardest part to teach people, is not to kind of come in, but you'll go down to a straight line until you get to the bottom of the
right there.
breast tissue. 1 more row. There you go. Now you make 1 fingertip adjustment over, and you make the next row up. And you repeat this in a vertical strip pattern all the way up to the collarbone. So if we look at the perimeter of what Brett is actually checking, It's everything from the collarbone to the inframammary ridge, or where the breast tissue ends. You come across to the breastbone, and then back under the armpit. So you've got quite a large perimeter here. It's an actual, like a pentagon or dress pattern shape, which most people don't recognize as being that wide an area to check. In this vertical strip method, we're trying to standardize the care in how clinicians and patients check themselves nationally, so everybody has a sense of confidence that they're getting a decent breast exam. For men, I would say, when it doesn't have anything to do with a menstrual cycle, as we always tell women postmenopausally, is to just pick the same day each month and do this as a monthly routine.
All right, very good. Anything else, Kathy?
I'd say one other thing, and Brett, remind me, I think I know your history too. Brett started out having a lump under the nipple. That's a common place for breast cancer to start, and it's the second most common place for women, but there could also be a nipple discharge. And I think if there's anything bloody or anything that's unusual or clear in color, that can also be a warning sign and not to be ignored. So it might not just be visually looking or actually palpating the breast, but let's not forget that the nipple can have symptoms too.
Yep. Well, very good. Brett, go ahead. I'm sorry. Go ahead, Brett. What?
I did have the discharge for about a year, not knowing that was a telltale sign of breast cancer.
All right. Very good. Well, listen, slip your shirt back on and your headset, and we'll sort of wrap this up here. I think this has just been a really fantastic session. Marcus, if you're hearing me back in Scottsdale, we can continue to move the camera around as we head into the last couple of minutes here. Kathy, when we think about the myths that might be associated with male breast cancer, or the failure, more likely, to diagnose male breast cancer, Kathy, what are your thoughts about the myths?
I think there's three things that come to mind for me. That it's not possible to happen in men, that it's not serious if you feel something, so don't worry about it. And really, if you feel something, there's no really good way to check men because it's a women's disease. And I think that's the three biggest things that really embarrass us when things go the other way.
Boy, I really, really strongly support that. Brett, from your perspective and as a national and now international spokesperson for men with breast cancer, what are your thoughts about the myths, and what should be sort of our wrap-up message for today's Google Hangout?
Well, I'm living proof that the myths are true, so they're not myths anymore. But if you have breast tissue, then you can get breast cancer. I mean, it's pretty much as simple as that. You're not, some people aren't as high risk as other people, but it's a possibility. Just knowing that it's a possibility.
Right. Now, during Male Breast Cancer Awareness Month, any particular events being planned or things you want to share as we close out this wonderful hangout with our audience?
Yes, actually, we will be wrapping up the month in New York City, April 26th and 27th, for a rooftop shoot. I don't have the picture, but essentially we will be on the rooftop of a bar in New York City called the 235th Club. It's the largest rooftop bar in New York City, and its backdrop is the Empire State Building. So we will have breast cancer survivors, supporters, men and women. It'll be only men survivors will be the only ones allowed in the picture. The rest will be either women survivors or women supporters, and it's a tops-off shoot. So you'll be naked from the waist up, and so the women will face the Empire State Building, so you see their back, and the men will face the camera.
Wow.
Showing their scars, showing their battle wounds.
Okay, well, we're going to, Brett, make sure that we get more information about that so that we get it out to our now over 600,000 followers at Breast Cancer Answers. We really want to promote this for you in a very, very big way. Brett, I think we're getting together here in a little under 2 weeks again. We're going to have another session to talk about a variety of things. Any other final thoughts, Brett Miller, that you've got?
just check yourself.
All right, man. And Kathy Freelander-Cole, any final thoughts that you have?
Well, as clinicians around the country, I think Brett is an example of how we can improve our own clinical skills and to keep awareness and to hopefully find a cure.
Yep, I'm with you all. Well, let me take this opportunity on behalf of Breast Cancer Answers to thank profusely my two wonderful guests. I thought this was a great hangout, very, very educational. More hangouts will be coming here at Breast Cancer Answers as the weeks and months go by. Please check out our home pages at Google+, Facebook, and Twitter for announcements of upcoming hangouts. For today, I'm your host, Jay Harness. We look forward to seeing you soon. Thanks for being with us today.
Thank you.